Hello, and thank you for joining us for this presentation entitled What's Really Going On? Identifying Depression and Suicide Risk in Men in Healthcare Settings. This presentation will provide an overview of the increasing rates of suicide among working-aged men, risk and protective factors, experience in hospitals and training medical students in this area, and how online screening programs can be an upstream strategy that can help get out in front of problems to prevent suicide among men. Healthy Men Michigan is an example of a statewide mental health screening and awareness campaign using online screening and resources to engage and educate about mental health and well-being with a focus on suicide prevention. The Healthy Men Michigan campaign offers free online mental health screenings, mental health educational information, and mental health resources for men throughout Michigan. The site is open to anyone, but specifically designed to appeal to men and their loved ones. Healthy Men Michigan provides immediate results based on answers to a brief screen, followed by comprehensive local, statewide, and national mental health, substance use, and crisis resources. The campaign is part of a larger research effort to evaluate innovative online programs to see what actually works for men to reduce suicidal thoughts and behaviors, and is supported by the cooperative agreement number shown here. Our panelists today are Dr. Brian Ahmedani, Dr. Jody Jacobson Fry, myself, Jill Fontaine, and Dr. Lawrence Fischetti. While Healthy Men Michigan is committed to safe messaging around suicide and prevention, we hope you will understand if someone's very personal story is left in its original form. Our panelists today will share experiences and current professional efforts in hospital settings and working with medical students, discuss how screening and data collection can help prevent suicide, provide an overview of the research study, describe the Healthy Men Michigan campaign, and explain how you can easily take action and get involved with the campaign promotional efforts throughout Michigan. We do have a full agenda, so we will likely not be able to take your questions. Please do still send us your questions through our survey that we'll be sending out at the end of the webinar, and if we're not able to get to them during the webinar, we will be sure to respond to them during a follow-up email. Please welcome Dr. Brian Ahmedani. Dr. Ahmedani is Director of Psychiatry Research and a research scientist at Henry Ford Health System in Detroit, Michigan. He is also a licensed clinical social worker. Dr. Ahmedani serves as investigator on several NIH-funded research studies in the area of suicide prevention, and his recent work has been published in more than 50 journal articles since 2011.
Okay, thanks, Jill. I really appreciate the introduction, and I'm really pleased to be here and happy to talk with everyone. So, essentially what I'm going to talk about is depression and suicide risk screening in healthcare settings, and this is going to be a pretty brief overview of some of the current practices. With the understanding that we have several different presentations today, you're going to hear a lot of different information about this. But this is sort of our experience and a little bit of information or research to support it. We can keep going to the next slide. So I do want to acknowledge that a lot of the work that I'm going to talk about was supported by grants from the Fund for Henry Ford Hospital, the National Institutes of Health, and the CDC. I don't have any conflicts of interest for this presentation. We can keep going. Okay, so this is the overall problem, and probably most of you know this, but about 25%, or 1 out of every 4 people, has a mental health condition at some point during their life, and that's pretty high number. It's a lot higher than most people recognize. That number is about 1 in 10 every year. And so this is a condition, specifically depression, that impacts a major proportion of our society. The biggest problem, though, with having depression is that, unlike a lot of other medical conditions where people are getting care pretty soon after identification of the disease, there's actually a pretty big gap in between the onset of depression and when people actually receive behavioral health specific services. So the estimated gap is about 8 years between the onset of symptoms and specialty treatment receipt. That's pretty startling. One of the major reasons for is that is that we're sometimes often missing depression symptoms when people come in for visits. Actually, the majority of people actually do make healthcare visits during a specific given year, but even men, but we're actually missing most of depression. So we need to do a better job with that. The other things that are going on with depression screening in healthcare systems is that, you know, it takes a while before people to get to behavioral health, and you know, most people are going to primary care or general medical settings. They, you know, in those types of settings, people, there is quite a you know, substantial backlog of other tasks that need to be accomplished during a standard primary care visit. So there is always a crunch for time. There's less training and also some discomfort from in primary care to manage these types of conditions. Although I think, at least related to depression, this has been improving in our understanding. So we can keep going. So, you know, one of the good things that's happened more recently in the last several years is that there are now quality standards from several organizations that basically require or strongly encourage depression screening in primary care settings. That's, you know, like I said, that primary care is the gateway, and depression is one of the most common conditions that occur. So what ended up happening, and this is sort of just by luck or by chance, is that many health systems sort of decided to use the same tool. Many of them started to use the PHQ-9, then in some variation of the PHQ-9. I'll show you a little bit about that in a minute. But the good thing about, now there are pros and cons about using different types of depression screening tools, but the good thing about using the same tool is that there's standardization across healthcare systems and settings. And so that, you know, if somebody goes to one setting and then transfers to another setting, people know what those scores mean from the same administration of a self-report screener like that, which is really important. But again, you know, I think we're also, it's not just about screening quality as in just doing screening, but actually fidelity to how you screen. So we're, you know, there are also problems with that, and we can talk about that. In specifically to suicide prevention, the Joint Commission now, you know, recently released the Sentinel Event Alert. Now, this is not a requirement; it's not a survey item for the Joint Commission, but it is a recommendation that suicide risk is screened for in most healthcare settings. The PHQ-9 actually does a pretty good job, the 9th item does a pretty good job of screening for suicide risk, in that, you know, with every increased level of how people respond, there's about a doubling of risk for suicide over the next 1 or 2 year period for a suicide attempt. So there are actually 3 different versions of the PHQ. There is a PHQ-2. All of them start with the base PHQ-9. There's 9 items. The PHQ-2 is essentially just the first 2 items. It's a really pretty good, quick depression screening tool. A lot of health systems do a PHQ-2, and then if people are positive on that, they'll ask the remaining items. Some places are actually doing a PHQ-8, which is essentially the whole PHQ depression screening inventory, the patient health questionnaire, except for the suicide risk. And, you know, there are a variety of reasons for that. You know, one of the pushbacks there is just worry about what to do if somebody's positive. I think that, you know, in my own understanding, it's good to, we should probably be asking about suicide risk in healthcare settings, and we need to ask those questions so that we can figure out how to act on that. Not asking doesn't mean that there is no suicide risk. It just means we're not asking about it. So let's go to the next. So here's the instrument, and there, like I said, there are a variety of ways to screen for depression and suicide risk, the Columbia screener. There's all sorts of different, for suicide risk, there's all sorts of different depression tools. It just so happens that a lot of the quality measures for healthcare systems actually specifically call out the PHQ-9 and are and most of the health systems decided to adopt this tool. So that's why I'm showing you this in more detail than other instruments. So you can see those first two items highlighted in the deeper blue color are the PHQ-2. All of the items except for the yellow item are the PHQ-8, and that last question there is the ninth item. We can keep going. So, my passion is suicide prevention. And, one of the things that's concerning about only asking the PHQ-2 before we ask the PHQ-9 is that not everyone who dies by suicide has depression. There are a lot of other conditions that, that may result in suicidal ideation or suicide attempt. In addition to the fact that I think the way this field is trending is that we really need to think about suicide as a separate condition and not as a symptom of another condition like depression. If we only rely on suicide screening among people who have depression, we're gonna miss at least half or more people, and our data suggests that we'd miss about half of the people who have suicide risk. So what you see here is our recent paper we had published showing where people go in what types of healthcare settings they're making visits before dying by suicide. This data includes about 6,000 people who died by, 5,800 people who died by suicide across several different states across the United States. What you see is that over 80% of people, 83% exactly, are making some type of healthcare visit in the year before they die. What's particularly important here that you'll note is that most of the visits are actually occurring in primary care settings without a mental health diagnosis coded. So that's that PC other orange line that you see. That's the most common visit type that people make before suicide. So what that means is that a mental health diagnosis is not coded during the visit for the primary care, a primary care visit during the year period at that visit before suicide. There are various other places, and actually the second most common place that people go for visits is actually an outpatient medical specialty setting without a mental health diagnosis. So basically what I'm saying is that the greatest risk for suicide is among people with mental health conditions, but if we necessarily only screen for people who have a mental health condition, we're actually going to miss the majority of people who are at risk for suicide. And that's why we have to think about doing this in primary care settings. It's certainly a barrier, so we have to work with our healthcare systems and finding the best strategies and approaches to do this because it is a very low base rate event. We can keep going. And specifically to men, about 81% of males, obviously this is less common than females, but still 4 out of 5 males make some sort of healthcare visit before they die by suicide. What's particularly important here that you'll see is that only 40% of males have a mental health diagnosis before they die. So that means 60% of males do not have a mental health diagnosis in the year before they die by suicide, and that means that actually more men do not have a mental health diagnosis than who do have a mental health diagnosis. And you'll see that about 62% of men have some sort of primary care visit without a mental health diagnosis before suicide. We can keep going. I went through this a little bit already, but I think the main message here is that this is an important thing to consider outside of behavioral health. If we only focus, people in behavioral health tend to be at higher risk because they, mental health conditions significantly increase risk for suicide. But only about 33% of people make it to a behavioral health visit in the year before they die by suicide. So since our suicides rate's been increasing by 25 to 30% over the last 15 years, the equivalent there is that if we did perfect suicide prevention and only did it in behavioral health, we would necessarily really only be able to flatline the national suicide rate, because we would miss, the 33% of people who make visits would just basically offset the increase in suicide rate we've been seeing over the last several decades. Another reason that we cannot only do this in behavioral health, we have to think about where else to do it. And we have to think about the best way to do it, working with our healthcare systems. Keep going. So just, this is the last slide I have, and I just, in addition to thinking about depression and suicide risk screening, another thing to keep in mind is that you should also think about screening for alcohol and anxiety. The GAD tool is actually works in tandem with the PHQ-9 to measure anxiety, so it's asked the questions in the same format. So we've done a PHQ-2, a GAD-2, a single item alcohol and drug screen question, and a suicide risk question, and that package of 7 questions, we've tested that out, and that seems to be a really quick, efficient way to screen for a lot of behavioral health conditions. And that's what I have for today. I'm happy to answer questions. I know we're going to not have enough time for those, but we can send them to the panelists, and I'm happy to respond later. Thanks.
Thank you so much, Dr. Ahmedani, for sharing your professional experiences, your research, and some of the staggering statistics that are really important to highlight the importance of screening in the primary care setting and focusing on this in the primary care setting as well, and really highlighting that for us. So thank you so much for your time and your research. I'm now honored to introduce Dr. Jody Jacobson Fry. Dr. Fry is an associate professor at the University of Maryland, Baltimore School of Social Work. Dr. Fry chairs the Employee Assistance Program, Subspecialization, and the Financial Social Work Initiative. Her MSW and PhDs were earned from the University of Maryland. Her research focuses on workplace behavioral health, including the impact of employee health and well-being on productivity and safety. She studies the effectiveness of employee assistance, work-life, and financial capability programs for working families and has dedicated a significant portion of her research agenda to the prevention of suicide and crisis response in the workplace. She is the immediate past chair of Subcommittee on Workplace Disaster Preparedness and Response for the Employee Assistance Professionals Association. In 2006, she was the recipient of the EAPA President's Award for Excellence, recognizing her work on this committee. Prior to teaching, Dr. Fry provided EAP and work-life services to NASA Goddard Space Flight Center, where she was recognized with several awards for her service to employees and family members immediately following the U.S. terrorist attacks on 9/11. She resides in Baltimore, Maryland with her husband and 2 sons, and Dr. Fry is the principal investigator and leading the parallel research study evaluating the online mental health programs used in the Healthy Men Michigan campaign. Dr. Fry.
Thank you, Jill, and thank you, Dr. Ahmedani and Dr. Fischetti, for being on this webinar today and joining us to talk about screening and response to suicide with men in the working aged years. So thank you, Brian, for talking about the importance of screening in primary care, and then also the importance of reaching out beyond primary care, but working within our healthcare systems to try to engage and connect folks that may be struggling and in need of additional services but are not well connected. And that's really what I'm going to talk about today. So Jill, go to my slides, and we can see here a quote from a recent report that I would encourage everyone to take a peek at if you haven't seen it already. This was the Suicide Prevention Resource Center did a report on men in their middle years, focusing on men's risk factors and needs that are in the ages of 35 to 64. And within this report, it really highlights the increase in suicide almost 30% since the year 2000 amongst men ages 25 to 64, making it the 5th leading cause of death. And this report, if you read into it, tells us that, historically, a lot of our focus in suicide prevention has been on youth and older adults, and not really on working age adults, and certainly not men in this age group. And without targeted interventions to engage men in assessment and mental health treatment, suicide will continue to increase among men in their middle years and will actually compromise a significant proportion of our population over the next 25 years. So this report, as well as some other statements and programs that are involved in suicide prevention, are really framing this as a public health challenge and need for a public health response to do a substantial reduction in suicide deaths among men in their middle years. Next slide. So when we think about men in Michigan, specifically the project that we're talking about today, the Healthy Men Michigan, focuses on men throughout the state, and suicide in Michigan is actually the leading cause of injury death among working age men. And so the project that many of you may be familiar with, or hopefully will be familiar with after this webinar, was designed to reach out at this unlikely at-risk population, and looking at the fact that males throughout Michigan and around the country are not only at high risk, but also have a lot of barriers to treatment, including a reluctance to often admit to emotional problems or discuss those problems, even with professionals and family. Sometimes are reluctant or question mental health diagnoses or services, and a lot of times don't know what services are out there in the community. And so that connection piece that Brian mentioned of needing to reach out and then connect folks back into the community is part of what we're trying to do here in Michigan. Next slide, please. So the Healthy Men Michigan project, before we get into that, actually, I think I might have missed a slide or two here. I did want to just mention a couple other risk factors, because Brian focuses a lot on depression, and then incorporated that last slide with alcohol and anxiety. And so this is something that the Healthy Men Michigan campaign is really looking at, where we're taking a platform for depression screening, but trying to go beyond mental health and thinking about what other risk factors there are for men in their middle years, with a strong focus on alcohol and substance use, as well as psychosocial needs like housing instability, economic and legal problems, and general life stressors as they might be related to relationship problems and other chronic health conditions. So you'll hear about some of this later on with Dr. Fischetti's presentation, but I do think it's important, particularly in Michigan right now, in thinking about the recent death of Representative Cavalli, that we were involved in trying to support our Upper Peninsula partners. But that connection with alcohol use is very strong, and from the CDC data, we can see that over a third of suicide deaths, people who died by suicide, actually tested positive for alcohol, according to the National Violent Death Reporting System. So we really need to look at expanding some of our screening and how we connect folks with different services. So Healthy Men Michigan is trying to blend 2 online programs, and you can see them up here, Screening for Mental Health and Man Therapy, as a way to go out into the community and reach men wherever they might be, whether it's at work or at home or other settings, any time of the day or night. When somebody is encouraged or decides to take an online screening for depression and suicide, they're then offered immediate feedback in terms of how they're doing on those screens, and connection to local resources that we've been working with in developing our partnerships throughout the state. Next slide, please. And so our 2 primary partners in the interventions that make up Healthy Men Michigan are Screening for Mental Health, who's hosting our webinar today, and they're probably best known for their National Depression Screening Day, which as an employee assistance professional in the field, I used their programs and worked with them for many years in doing depression screenings in the workplace as a real public health way to get out and not only do prevention, but early intervention and thinking about depression as a way to link folks to services. So our platform for Healthy Men Michigan has access to these other screenings, alcohol, eating disorders, anxiety, but we're really focusing on depression as our launching point and then expanding from there. Next slide. Now, Man Therapy is an interesting program that comes out of Colorado in a joint effort from the Colorado Office of Suicide Prevention, the Carson J. Spencer Foundation, and Cactus, which is a marketing firm. And Man Therapy has been gaining a lot of popularity over the past several years in the U.S. and now in Australia. It was designed to provide additional online screening services for middle-aged men, but also to link them to services and engage them in help-seeking behavior using a very out-of-the-box from traditional mental health services perspective, and specifically using humor to talk about mental health, mental fitness, well-being, as well as suicide. So you see on the slide here Dr. Rich Mahogany, who's a fictitious doctor who talks with men who go on mantherapy.org about their mental health and well-being and shares videos and tips as well as links to resources. Next slide. So how do these come together? At the time of the CDC grant that is funding our project, which we're quite grateful for them to really invest in this population and these online potential innovative interventions. In Massachusetts, a program was developing called Mass Men, and Screening for Mental Health and Man Therapy were coming together as a way to further reach out to this very hard to reach population that is at risk for suicide, to let them have an opportunity to take a screening for depression or to visit the Man Therapy website. And so when we were initially conceptualizing and working with our partners in Michigan, we used the Mass Men as a foundation to learn from and to improve some strategies. But what we did find with Mass Men is by targeting men specifically in online screening, the numbers reversed. It was almost like magic, where traditionally women are much more likely to go online and do depression screening or any screening for mental health. Almost 70 to 30% gender split. And with Mass Men, about 70% of the people going to that website were men. So there was something there about targeting the messaging and the campaign for men that seemed to be working, but Mass Men lacked the research base that we've built into Healthy Men Michigan. Next slide, please. So this is just a snapshot of the University of Maryland where I'm working, and we're doing the research out of here, but all the programming takes place in Michigan and is online with referrals to community partners, such as yourself on the call today. So this just gives kind of an overview for those of you interested in the research, but we'll be collecting data online through the end of August 2018. And we're trying very hard to reach out to as many men as possible throughout the state to do the online depression and suicide screening. And if they score at a certain level on those indicators, and they're in our age range, which we've just expanded actually for working age men to be 25 to 64, then they're invited to be in a voluntary study for which they receive compensation for their time, which is doing some surveys. And we get some feedback from them in thinking not only, did these websites help to increase help-seeking behavior and reduce suicide ideation behavior, and some other risk factors that we're looking for, but is this also an effective way to reach out to men? And what can we learn from them in terms of improving services in the future? So this is really the first randomized controlled trial that is trying to look at the additive effect of adding Man Therapy to a more traditional online depression and suicide screening. So we're excited to be able to partner with Michigan to do this program, and looking forward to talking with all of you on the phone about ways that we might be able to be partners at some point. Next slide. I think that might be my last slide. So I'm going to turn it back over to Jill, and thanks for sharing this time with us for those of you on the call on your lunch break today.
Thank you so much, Dr. Fry, for talking to us about the research supporting this campaign. I'm Jill Fontaine, the Program Manager for Community Response and Contracts at Screening for Mental Health. At Screening for Mental Health, my team and I are responsible for the day-to-day campaign implementation of Healthy Men Michigan, including outreach and community engagement, promotional partner recruitment, and campaign promotion. So welcome to our Healthy Men Michigan campaign homepage, which is at healthymenmichigan.org. Our campaign launched on September 26, 2016, and will be live, as Jody mentioned, through August 31st, 2018. As you can see from the homepage, there is a brief description of the campaign and the opportunity to take a screening. We have also included a link to our previous webinars and a quick link at the top to the Healthy Men Michigan promotional toolkit, which we'll discuss in more detail later in this presentation. Once users have completed the screening, they will be given resources based on their geographic area, and users who fit the criteria for the research study are able to opt in at the end of the screening. So in building the partnership and campaign outreach and engagement, I wanted to give you a bit of background to how we organized all of our groupings and how we completed all of our outreach at this grassroots level. To engage organizational leaders, we developed a strategic method to reach organizations both pre- and post-campaign launch and continue to actively develop innovative and cost-effective ways to engage our organizations and partners throughout Michigan. We organized our outreach efforts into 3 groups, as you can see here on the slide, with natural overlaps, and totaled to approximately 1,050 organizations who heard from our team. These included mental and behavioral health organizations and suicide prevention organizations and groups, education, health and safety and emergency services groups, and faith-based organizations. Our third group included businesses through chambers of commerce, in addition to male-dominated industries, and various clubs and groups where male congregate in larger groups. We reached out to behavioral health and suicide prevention organizations first so that we can engage them as referral resources as well as promotional partners. The campaign engaged over 60 behavioral health and suicide prevention resource and promotional partners throughout the state of Michigan. They're listed on our resources page of the Healthy Men Michigan site, which is available to users once they've completed the screening. We are currently reaching out and hosting webinars targeting those individuals in male-dominated industries, including in the past veterans and military, construction, and first responders and public safety officials. Future outreach will include transportation sector and sports-related industries. We currently have a total of 103 partner organizations or groups and 163 individual partners throughout Michigan. In the next few slides, I'll share a number of ways in which you and your organization can help promote the campaign throughout Michigan. Since the launch of the campaign, more than 946 individuals have taken a screening and been referred to local resources in their community. A good number of people report they are hearing about the campaign from their employers, in addition to word of mouth by family members, neighbors and friends, and healthcare and mental health settings. HealthyMenMichigan.org is actively working to meet men where they are at any time, and we're helping men to learn that taking control of mental health is a manly thing to do. So as one of our valued partners on Michigan's statewide campaign, we work together to promote the initiative and encourage men to access the HealthyMenMichigan.org website. We'll work with your organization to build mental health awareness activities and events and provide customizable marketing materials to aid in your campaign efforts. As you can see here, we have 3 options listed, including our digital toolkit, which is called the Promotional Toolkit on the site and contains everything you need to tell the world about Healthy Men Michigan, including social media posts, social media images, and more. We also have our online shop where you can order magnets, coasters, flyers, and wallet cards, and can order the materials on the shop free of charge at any time. The third tool is the Downloadable Resource Center, and it is an additional tool you can use that has press releases, flyers, and other customizable promotional materials, including short PSAs that can be included in radio segments. We'll be sending you links to access all of these materials after our webinar. There will also be a link to the full DRC materials after the webinar, and we ask that you fill out the follow-up email survey after accessing our DRC so that we can stay up to date on the ways that our promotional partners are going to use materials and we can track the effectiveness of outreach strategies. Please also send us pictures and share on social media when you use materials to promote at events, and we'll be highlighting partners in upcoming Healthy Men Michigan e-newsletters who share photos and further promote our partners' efforts. Here are some examples of our Michigan community outreach from partners throughout the state. Barb Smith, founder and facilitator of Saginaw Survivors of Suicide, is pictured here with her campaign efforts, in addition to Lisa from Kirsten's Ride, and also Gail and her team from Kevin's Song have sent us their outreach efforts throughout the community, and we appreciate all of the partnership and photos that you continue to share with our team. You can also spread the word about the campaign by liking us on Facebook, following on Twitter, or emailing us and visiting healthymenmichigan.org. I am now thrilled to introduce Dr. Lawrence Fischetti. Dr. Fischetti completed his bachelor's degree in psychology at Towson State University in 1976. He completed his doctoral training in clinical psychology at Bowling Green State University in 1985, followed by a postdoctoral fellowship in the Department of Family Medicine, Wayne State University School of Medicine. His teaching interests include the patient-centered clinical method, physician wellness, and professionalism. Clinical interests include individual therapy with teens and adults, couple and family therapy, and clinical supervision. Dr. Fischetti is the Associate Director of Behavioral Science and Community Medicine at Oakwood Annapolis Family Medicine Residency Program and the Director of Communication and General Competency Training at Oakwood Hospital Department of Medical Education. Dr. Fischetti.
Okay, thank you, Jill, and thank you, Brian and Jody, for the opportunity to talk about depression and suicidality in men. Some of my information is consistent with what the audience has heard from the other speakers. I'm going to focus a bit more in physician depression and suicidality. Next slide, please. You've heard that depression is primarily a problem of women, and from the lifetime prevalence data you can see that as many as a quarter of all women experience an episode of major depression. So it is a huge public health problem. The percentages or prevalence is about half that in men, but still with 1 in 8 experiencing major depression in their lifetime. Annually, we expect about 1 in 10 U.S. adults, and in primary care where I work, at any time, at least 10% of our patients are suffering significant depressive symptomatology. In the hospital setting, as you would expect, those rates are much higher. Next slide. Illness burden is a composite member that includes costs, treatment, lost productivity, as well as illness days. Some years ago, the World Health Organization projected that the year 2020, depression would be the second on the list of causes of illness burden and the #1 cause of disability. We tend to think of depression as an episodic disorder with people recovering completely between episodes, but at least 20 to 30% of patients suffer continuous symptoms, which is another indicator of how disabling the condition is. Not just emotionally or psychologically, but physiologically. Major depression is a risk factor, as you see, for myocardial infarction, as well as cardiovascular death. Next slide. With respect to suicide risk, as the other speakers have noted, major depression is a major risk factor, accounting for 2 of 3 suicides, and individuals with severe depression, approximately 15% will take their life at some point. Like the data that Jody was presenting, data coming from the UK found that the rate of suicide increased over a 2-decade period among young men. But since that period, particularly the last 10 years, the highest rates have been among middle-aged working-class men. Next slide. Among the predictors beyond age was low socioeconomic status, also relationship loss. Women seem to maintain close female relationships throughout their lifetime. However, for men, by age 30, they tend to be losing their close friendships. That leaves them particularly vulnerable emotionally on their partners, and if they lose that relationship through separation or divorce, they are quite vulnerable. Economic loss is a common precipitant, either through job loss or some other economic disaster. As some of the other panelists mentioned, men tend not to seek help. They're very stoic about their emotional distress and much less likely than women to seek mental health care. Particularly in low SES groups, there's excessive use of alcohol and drugs when distressed. which adds to the mix. Self-criticism is a personality feature that tends to predispose. And signs of increased risk include irritability, increased aggression, verbal or physical. They tend not to talk about it, but if you do hear any indication of a plan, that's a very serious warning sign. And another major reason suicide is access to lethal means, and tend to use more lethal means, and firearms in particular. Next slide. I think the audience is familiar with the diagnosis of major depression. 5 of 9 criteria present most of the day, nearly every day, over a period of at least 2 weeks. Next slide. While the UK study and some of the data that was presented previously focused on the risk of men in lower socioeconomic strata, it may be surprising that physicians are at the highest rungs of the socioeconomic ladder are also at significant risk for depression and suicide. Lot Derby and Tate Shanafelt at the Mayo Clinic have been researching physician distress for at least 15 years. This is a quotation, a summary of the research from their 2012 publication, suggesting that at least 10 to 20% of physicians suffer depression. Nearly half experience burnout, and many more. Poor quality of life, dissatisfaction with work-life balance, and high degrees of stress and fatigue. Next slide, please. And somewhat like the information that's been shared about men in general, physicians tend not to acknowledge their depression. They assume that everyone's depressed, and that's, or stressed, I should say. Medicine's very difficult, and that you should just bear with it. They tend not to seek help, part of the stoicism, but in some cases they do not want it to be known, or they fear loss of licensure. And physicians who are distressed tend to misuse alcohol. And in particular, those that are experiencing burnout contemplate leaving practice in a number of ways. Some consider restricting the scope of practice. Others, particularly if they're near retirement, think they're going to get out of the business early. And even some young physicians plan to leave medicine altogether. Beyond burnout, physicians are vulnerable to suicide. Increasingly, it's been recognized that about 400 medical students, residents, and practicing physicians take their lives each year. Shanafelt did a recent study and was surprised to find that 6% of his surgeon colleagues had contemplated suicide in the last year. And physician distress is related to lapses in professionalism, whether that be interactions with colleagues or with patients, and those lapses increase the risk of medical errors and endanger patient safety. Next slide. The response to physician distress has come from all corners: medical societies, hospital groups. Previously, Joint Commission was mentioned, and a big focus has been on organizational supports. Colleagues of mine at Beaumont Health have put together an ambitious plan to support physician well-being. Part of that process involves bringing administrative leaders and clinical leaders together to look at processes in medical care and to help make them more efficient, to provide resources where they're needed, and in various ways to help physicians feel more productive and less frustrated in their work. Big emphasis on team function, communication, and part of that, I work with a group of psychologists and social workers at Beaumont. Our interest is in helping to place behavioral health professionals in specialty and primary care clinics where we work closely with physicians. This takes a lot of the weight of medical work off physicians when they encounter behavioral health problems or mental health problems. It also allows us to provide better care to patients, often with brief interventions. And Beaumont has worked with colleagues at Vanderbilt University to address lapses in professionalism. The cup of coffee intervention is well known in medicine and medical education. Essentially what that involves is a trained physician. When there's a complaint, he schedules an informal meeting with the colleague. I have some information to share with you. I thought this would be important for you to know, and this is what has been reported. Tell me what your thoughts are, what's your reaction. What ideas do you have on avoiding this kind of perception in the future? And though many physicians are uncomfortable with the information and the complaint, the fact is that they take it to heart, and the evidence is very good that they are able to change their behavior as needed to avoid future complaints. So that's part of the effort here at Beaumont. The Accreditation Council for Graduate Medical Education, or ACGME for short, covers all MD training residency programs. DO programs are under a different structure, but within the next few years, it'll all be merged under the ACGME umbrella. And back in 2003, the ACGME implemented work hours, limiting resident physicians to 80-hour weeks, which is still very high. But prior to that, surgery residents reported working over 100 hours a week, so it was a big change for many in medical education. Similar emphasis on team function. And in terms of the teaching, in recent years, the ACGME has instituted the Milestones project. This establishes specific competencies that we expect residents to achieve at each level of training. And so the training is focused on that. There's evaluation, and there's help when residents are lagging behind in their progress. Also, in terms of monitoring, I'm part of the counseling and support team in Beaumont Dearborn. One of our projects is annual resident wellness days. We get together with our residents for a half-day, fun, working with each other. It should be enjoyable, and we have an opportunity to talk about healthy lifestyle and help them prepare for the stresses of future practice. We also monitor fatigue informally on a daily basis, and more formally once a year using the Epworth Sleepiness Scale. We've been doing that for 4 years now, and our evidence is that our residents, about 20% at any time, are experiencing excessive fatigue. But by and large, our numbers are much better than what we see in the published literature, and we're always trying to reduce that number. We're also beginning to implement screening for burnout and distress in the advisor meetings, which are semi-annual. Another part is preparing our residents to treat depression in primary care. As it was mentioned earlier, men tend not to seek mental health treatment, and when they suffer depression, they focus more on the physical symptoms, which makes it natural for them to seek help in primary care. And over the last 3 decades, there is increasing evidence for the effectiveness of treatment in primary care. Increasingly, physicians are using a combination of medications and verbal therapy. Also, a study from some years ago using problem-solving therapy for primary care. The outcomes were good, and it showed that general practitioners trained in a time-limited model had outcomes that were similar to psychiatrists using the same model. So good news there. Part of the training here in family medicine and other primary care programs involves screening. The PHQ is mentioned. The Healthy Michigan screening tool that's available online includes the same items as well as additional items that look at suicidality and help link individuals to local resources. We have a psychiatrist in our residency program. She provides training on diagnosis and psychotropics. In many cases, primary care doctors have limited access to psychiatric support, so they need to be familiar with these medications, indications, and some of the risks. And a big part of my teaching is primary care counseling. Next slide, please. The model that we use is a composite of the work of Jerome Frank, psychiatrist and psychologist from Johns Hopkins University. Years ago, Jerome Frank found that most forms of psychotherapy were similarly effective for a wide range of problems, and he proposed the only reason that that could be true is that therapists are doing very similar things. And one of the big parts of the therapeutic component is to strengthen the relationship with the patient. Particularly with men, we know that they're isolated. They have some difficulty talking about what's going on and how they're feeling. And if they can make a connection with the physician or the therapist, that helps to alleviate their isolation. It also is part of instilling hope. Frank mentioned that about 80% of people seeking help are demoralized, and so when we help them to feel understood and say, we're going to work with you on that, that's a good start to helping them with their problem. Another component involves assessing emotional suffering, what kind of loss the person's experienced, how they've tried to manage it, what else have they considered. Social supports, particularly in suicidality. I ask patients, well, who else knows that you've been thinking like this, that you've had these feelings? And certainly with men, the answer is, well, no one. And so part of my task is to ask them to, well, I tell you what, let's talk about who you might talk to about this beside the two of us. And if the individual still has some difficulty, I say, okay, well, next time when we meet, let's talk more about that. And the effort is to help restore the individual's sense of self, their lost confidence, and perhaps to find some meaning in what's happening in their life. Next slide. Physicians are very good at providing explanations for medical phenomena. Here we want them to construct an impression that links events in the patient's life, stress they're experiencing, and their symptoms, to take into account the patient's thoughts, and then to make sure that we're in agreement of what's going on here. And another part of that is to say, not only do we understand this, but we know what to do about it to help you feel that you can handle this situation and get back to feeling more like yourself. Next slide. And at some point, the rubber has to hit the road. Behavioral activation, at least modest physical activity, exercise is very important. Depressed patients tend to be consumed with what they're feeling, their misery, and trying to figure out what to do about the problems in their life, and that distracts them from the world and their sensory experience. We want to correct that. Walks is one possibility, pleasant music, for some people movies. Also, we want to correct the withdrawal that's typical, at least some minimal social interaction. And while mindfulness is not for everyone, it's very effective in the treatment of depression and has had benefits for physician groups that have pursued it. Other parts include practical problem solving, a plan for safety, and reminding the patient that they have had numerous hurdles in life that they've overcome, and that we're going to work together to get them past this point. So that's the teaching in primary care. In terms of skill level, I'm very impressed with my physician colleagues, the faculty in the program. They have very loyal relationships with patients, and our residents as well. They're a very empathic group. They make a strong connection, and we look forward to them to stay locally and having an impact on public health. Thank you.
Thank you very much, Dr. Fischetti, for sharing your experiences and working with medical students and training in the primary care counseling setting as well, and in some of the research and areas that you're working in wellness with our physicians as well, and training medical residents as they're going through that difficult process, and reminding of some of those important health components of it as they're looking forward to treat their patients in the future as well. So thank you for making those connections to us and the importance of these efforts that we are working on together. So this is our call to action, summarizing everything together here. Thank you for joining us on this webinar, and we want to remind all of you in Michigan how you can help men in Michigan take action, and how you can help spread the word about men's mental fitness throughout the state. We have this slide that will be available for you as a handout as well, and look forward to your partnership efforts as we continue on this important campaign in reducing suicide rates among men in the state of Michigan and nationally as well. So if you have additional questions, we will be available by email. For more information about the research, you can contact Dr. Jody Jacobson Fry, and about the campaign myself. And again, you can see the handouts that will be available for you, including a flyer with more information about suicide prevention in the primary care setting from the Suicide Prevention Resource Center, and those will be attached on handouts after this webinar. So thank you so much for joining us, and we hope to connect with you all as part of the Healthy Men Michigan campaign. Thank you.